like to thank our generous sponsors, Peninsula Hot Springs, who have made tonight's consumer webinar possible. Located on the picturesque Mornington Peninsula, Peninsula Hot Springs has been a valued part of Musculoskeletal Health Australia since 2016. Peninsula Hot Springs is renowned for its geothermal hot springs and day spa and has garnered numerous awards for its exceptional services. What many of you may not know, the study of the therapeutic benefits of natural mineral waters, or I'll get this wrong, balinology, supports the positive effects of hot springs bathing. Extensive scientific research over many years has demonstrated the efficacy of baliotherapy, particularly for conditions such as chronic back pain and arthritis. Since its humble beginnings in 1997, when brothers Charles and Richard Davidson envisaged a unique bathing experience, Peninsula Hot Springs has evolved into a wellbeing sanctuary with a dedicated team of over 350 professionals who now offer more than 70 globally inspired bathing experiences, along with premium accommodation, cultural events, and transformative wellness activities. Peninsula Hot Springs is a definite place where you can go to relax, recharge, and rejuvenate. Thank you for joining us for tonight's webinar. My name is Helen Gents, and I have the pleasure of introducing our amazing presenter this evening. Before I do that, I would like to take this opportunity to acknowledge the traditional owners of the lands from which we are joining the webinar this evening and pay our respects to their elders, past, present, and emerging. Also, if this evening's webinar raises any questions or concerns, please make sure you call the Musculoskeletal Health Australia Back Pain, Arthritis and Musculoskeletal Conditions, or as we like to call it, BAM, helpline on 1800-263-265 to speak with our highly qualified healthcare professionals. Now to our presenter. Dr. Christian Barton is a physiotherapist who has focused his research and practice on the management of persistent and long-term injuries. He has a special interest in knee pain and osteoarthritis, or OA, as well as running-related injuries. He is also an associate professor at Trobe University's Sport and Exercise Medicine Research Centre in Melbourne and leads numerous projects related to facilitating patient and health professional education via digital and social media through the Translating Research Evidence and Knowledge, or TREC, initiative. Christian also leads the Good Life with Osteoarthritis Denmark program in Australia, which aims to improve access to appropriate exercise and education to all Australians with OA. This evening, Christian will be talking about the importance of prescribed exercise and getting active to help manage knee osteoarthritis. The numerous benefits of exercise for osteoarthritis and general health will be discussed, and guidance on how to address pain to get active again provided. I'm sure there'll also be a number of myths discussed and busted during the presentation. So on that note, welcome, Christian.
Thank you very much, Helen. Thanks for the kind introduction and welcome everyone. I'll just share my screen to bring up some slides. So just bear with me for a second while I do that. So I've got the pleasure of talking to everyone tonight about, I guess, a pet topic of mine, which is using exercise and physical activity for managing osteoarthritis and in general musculoskeletal pain. It's something I have a big focus on in my clinic. So I work a couple of days a week in a clinic in Richmond called Complete, and the rest of my time I spend at Trobe University doing research and teaching, with my research focused on how we actually translate what we know from an evidence perspective into practice and actually get it into the hands of consumers who need to use it. And then outside of that, I'm busy running around with 3 young kids who keep me very busy also. So just want to say thank you for many funders and supporters, and in particular the APA. So I'm a physio by background and get a lot of really good support from the APA, the Medical Research Future Fund, which is a government funding body. And then Helen mentioned a couple of not-for-profit initiatives, so both GLAD and TREC, which I'll talk a little bit about through the presentation. So what are we talking about tonight? I'm going to focus on knee osteoarthritis, but there may be questions from the audience about hip osteoarthritis or hand or other joints, and we can certainly touch on them. I think one of the things I want to highlight is the key messages that I share with you about the knee can absolutely be applied to other joints in the body. And so the symptoms of knee osteoarthritis are typically pain, stiffness, particularly in the morning, may get reduced mobility, may describe instability for some people, so the knee giving way, and some people describe crepitus or noisy knees. So they're common symptoms that we might see in someone with knee osteoarthritis. A lot of people will focus on their x-rays, which we'll have a talk about the validity of that in a little while. So there might be some changes on their imaging. So the things I'm going to cover tonight is I really want you to take home the key point that exercise and physical activity are the key to managing osteoarthritis well. And in fact, if you're not getting that right, you really shouldn't be moving on to other interventions. They're the really key components. Other treatments might help, but they shouldn't replace exercise and physical activity. Exercise is typically good for your joints. I want to talk about a few myths later about exercise and whether it's harmful or actually helpful for the health of your joint. And exercise is also very good for our general health, which we'll touch on. There's lots of options to engage in exercise and physical activity, and hopefully I'll share some with you, both where you may seek a health professional support, but I'm also going to share some online resources that will hopefully help you moving forward if you've got osteoarthritis that are freely available, so you can engage with some support around exercise and physical activity. So if I talk about the evidence, I'm a researcher, so I have to start with the evidence. I promise it won't be an evidence-filled presentation, but I will touch on a few bits and pieces. I want to orientate you to a graph here, which is produced by the GLAD International Group. So GLAD standing for Good Life with Arthritis from Denmark. And so it's a program that we've adopted here in Australia, and I'll talk more about that in a while. But this graph basically highlights the evidence for exercise compared to not doing exercise. And those not familiar with reading data on a graph in a research paper like this, the top line you see here with the little diamond, the dot, that would be the estimated effect of exercise. So on the right would indicate exercise is better, the left would indicate that the control condition is better. So what you'll notice is all those dots sit on the right-hand side and they kind of end up on about a 0.5, which is a moderate effect, which is a good outcome for exercise. You'll notice the lines that come off them, they actually start to shrink more and more. So those lines are the confidence we have in that dot as each trial gets added. So for example, the first line just includes the 1992 trial. The second line includes the 92 and the 93 trial. The third line adds the 96 trial. The fourth line adds the second 96 trial. So we slowly become more and more confident in what the finding is. What the evidence suggests when we look at a synthesis of all of this is that we actually had enough evidence as of 2002 that doing exercise compared to not doing exercise was beneficial for improving pain and improving function. So any randomized trial completed after that to test whether exercise is beneficial to not doing exercise was possibly a waste of funding and waste of time in terms of doing it. What type of exercise you might want to ask? Well, there's varying different types, and there doesn't seem to be a superior exercise when we apply it across the board to people. So it may be aerobic exercise, so thinking about bike, water exercise. It might be strength training, or it might be neuromuscular exercise, which is a fancy way of saying trying to improve the way we move when we're doing exercise. So all these different types can be helpful. So what are the recommendations from clinical practice guidelines? So what should we be providing in our clinic? So whether we're a physio, GP, whatever it might be, we did a systematic review of the guidelines recently. And what we found is we looked at just the higher quality guidelines. So there was actually around about 30 guidelines across the world, but we actually summarized the top 6 of those. And what you'll notice is you see some really clear guidance around exercise. So the green dots on here would indicate that there's support for these types of interventions. Red would indicate that there is support against providing these interventions. So you'll notice that opioids has some red dots with it. If you go all the way to the bottom, arthroscopy surgery, red dots. If we look at exercise, education, and weight loss, which is kind of the cornerstone of treatment, you'll notice the green dots are pretty bright green, and that's across all the guidelines. So it's really clear based on evidence and guidelines that we should be providing exercise to people with osteoarthritis. So what happens in Australia? Most people will go to their GP when they're seeking healthcare, and there's some really interesting research looking at what GPs typically prescribe or refer to in Australia. So this is a really large data set across around 11-year window. And what it tells us is that 13 to 16% of people with hip or knee osteoarthritis are referred to see the surgeon. Around 15 to 26% are prescribed things like anti-inflammatories and opioids and those types of medications, things that often we should try and avoid. And if we look at referral to a physio or an exercise physiologist who might support us with exercise, it's around about 5%. So you're 3 times more likely to be sent to the surgeon than you are to be sent for support with exercise, which is a little bit concerning, especially me as a physio who's biased towards exercise. We recently had the clinical care standards released, and I just want to highlight that. It's well worth a read if you want to read more about what we should be doing for management of osteoarthritis. I had the pleasure of reviewing this before it was actually published. And I just highlighted a few things in relation to physical activity and exercise. And it's really clear that this document too, which is produced by the government, recommends that we should be helping people with exercise and physical activity. There's also some really nice advice about pain and discomfort and exercise being safe for your knee. So hopefully that'll make more sense by the end of tonight. And then there's recommendations, if we look towards the bottom, that we should be looking to refer people for a specialist clinic to local community programs, groups or activities, maybe physio, exercise physiologist or exercise physician, or potentially a multidisciplinary service. But I go back to the data I presented before, just 1 in 20 people seeking help from their GP are actually referred to a physio or to an exercise physiologist or for that support for exercise. So we have a big problem in terms of what we're providing in evidence-based when it comes to clinical practice. So I want to introduce you to a patient. I'm going to go through a few case studies through this presentation to break it up a little bit, but also to give you guys a good feel for the lived experience of different people with osteoarthritis. I'm going to let Helen tell her story for a couple of minutes.
3 years ago, you fell down the stairs and injured yourself at work. You injured your knee. You were eventually diagnosed with a broken kneecap and a torn patella tendon, and you were referred to an orthopaedic surgeon. What advice were you given?
I was advised that if I didn't want an operation, to rest and to do not move at all. So I sat on the couch for 6 months in a brace and did exactly what he said.
And how did your body react to that?
Well, beforehand I was very active and then I did nothing. So I was like a cage fly and I was horrible, very horrible.
What do you mean you were horrible?
I think you're frustrated. I worked from home. I'm an accountant, so I could still work. So all of a sudden I lost my independence. It was my right leg, so I couldn't drive. I couldn't walk down the stairs without any help.
What happened to your overall health after that 6 months of inactivity?
The muscle atrophy in my legs were terrible in both legs, but especially my right leg, because at least I was hopping on my left leg. I put on a lot of weight, and I just felt really sluggish. But
and you developed high blood pressure?
I did develop high blood pressure. That came to light probably 6 months afterwards, but it was this because the weight gain was pretty, I put on about 12 kilos really quickly.
And you developed osteoarthritis in the knee?
Yes.
Rob, you're an exercise physiologist. What happens to your muscles when you stop exercising?
It regresses quite quickly, in particular when you go to total rest of the muscle, in your case with the injury, and you couldn't use them at all. So the muscles change quite rapidly. They get smaller, of course, but the issue also is you can have infiltration of fat and fibrotic changes within the muscle, and they're really hard to reverse.
Helen, you sought some advice and got a second opinion. What did that second surgeon say?
That I need an operation.
And you wanted to avoid that, didn't you?
I wanted to avoid. You're never the same after an operation. I did my Achilles tendon 15 years earlier, and every morning I still have to stretch it. So I wanted to avoid the operation.
So you got referred to a physiotherapist. What happened then?
He put me straight in the gym because when I came out of the splint, I had to learn how to bend my leg again and to walk. And probably about 12 months after the accident, I just went straight in the gym and was told to do leg extension, leg presses, hamstring curls. And I just could not lift the bare bar. And I'd go home and my knee would swell and it just created pain. And then he said, well, just walk. So I walked a hell of a lot on the flat and then my knee would swell.
So we'll come back to Helen. You'll notice that she had a long period of rest and immobility. And as she talked about the deconditioning, it was affecting her mental health, was affecting her cardiovascular health. She was given some support with exercise, but the exercise prescription she was given initially was not all that effective. And we'll talk about why that might be later. But at that point, she'd basically given up on exercise as had other health professionals, which is maybe not the best approach for Helen. And you'll see that as we go through things, there was actually a pathway forward for her with exercise. So I guess the question is, what is exercise? So when we talk about it, I think a really key point is it can be many different things. So for some people, they'll tell us that, look, I'm already doing a lot of exercise, do lots of exercise at work. I'm a farmer, or I'm a labourer, or I do building, or I do this, I do that. I'm on my feet all the time. But what we need to really understand is that exercise can be many different things. And the way we can think about it is we can do physical activity. So these can be occupation activities or recreation activities. So things we do that get our heart rate up, get our body moving, and they're really beneficial for everybody. Regular physical activity can reduce our risk of at least 35 different chronic diseases. But then when it comes to a condition like back pain, or in this case, osteoarthritis, we can also think about exercise therapy or therapeutic exercise. And what we need to do often with people with osteoarthritis is to understand what are the key barriers to them doing exercise and physical activity, and what are the things that we can address to make their condition better. And so we might look at things like pain-related fear. So it might be trying to get them gradually doing things. It might be neuromuscular exercise and functional exercises, teaching them to move a little bit differently so they can reduce their symptoms. It might be endurance-based exercise or improving muscular strength and power. We might prescribe exercise to improve flexibility. It might be aerobic conditioning, so a simple walking program or cycling program. And all these different things can have different therapeutic benefits depending on the person and depending on what they actually need. So exercise is not all equal, and it's a really important message that I think you really need to take home, and we need to promote a lot more widely in the community. So this led us to think about a program, so this barrier of why are people not doing exercise. And I'm a physio, so I'm going to reflect internally and say that a lot of us physios may not prescribe exercise enough. Other health professionals the same, and that might be one of the reasons that people aren't referred. We may not get our exercise approach right every time. And so we started to work with a group from Denmark, and this was a group who were implementing GLAD. So Soren Skue and Eva Roos, both professors there. And the idea of GLAD is to train physiotherapists into providing and prescribing specific exercise for osteoarthritis, how to prescribe, and then how to progress the program. And I'll talk a little bit more about it in a second. They then go back to their clinics and they deliver the program alongside education about the condition. And importantly, we collect data so we know what the outcomes are and we know how we can tailor and improve the program based on that. So there's a large registry that we have. So if we talk about exercise and physical activity for people with osteoarthritis, we can look at systematic reviews and we can look at this evidence and make a few key recommendations on what an exercise program should or could look like as best practice. So the key recommendations that we've come up with from some of our research is that we need to tailor the exercise program to the individual patient, so their needs and their preferences. We might consider water-based exercise or chair-based exercise, but it's not going to be as effective as land-based exercise, and that'll make more sense shortly. We need to provide a minimum dose. So it's no different to taking antibiotics or another medication. Exercise can be considered like this, and our minimum dose of exercise based on science and evidence seems to be 12 exercise sessions that go for 30 to 60 minutes, spread over a 6-week period, so 2 sessions a week. We do get better improvements if we can extend that program to 12 weeks, so still doing at least 2 a week, and potentially doing 3 or 4 sessions a week instead of 2. So of course, the more support and sessions you might do with a physio or an exercise physiologist, the more costs associated with that. So in GLAD, we've kept the program to that minimum of 12 sessions over 6 weeks. We also need to include patient education and think about boosters. We need to educate people and reassure them about managing pain during exercise, inflammation, how to modify other exercise and physical activity. So it's not just about prescribing exercise, it's also about the education components too. And so what does the GLAD program look like, which I'm going to talk about some of the outcomes. There's 12 60-minute sessions. There's a range of exercises looking at lunging activities and starting with sliders. There's functional exercises, looking at chair stands and stairs, things people commonly have trouble with. There's exercises to improve knee strength, improve hip strength, and improve trunk strength. Those who want to explore the exercise a little more, that website there, nemex.track-education, has many of the exercises and progressions online, so feel free to have an explore. But I'll just play one of the exercises now so you can get a bit of a feel for what some of them might be.
Stand weight bearing on one leg with the other leg on a sliding surface. Slide backwards to forwards with the sliding leg whilst flexing and extending the knee of the weight bearing leg. Ensure you are keeping good alignment of the shoulder, hip, knee and foot. To perform this on carpet, you may use a slide pad, which can be purchased from your physiotherapist. To progress this exercise, you can reduce the amount of upper limb support, increase the repetitions, increase the speed of the movement, or take a longer slide. If you find your knee falling inside of the foot, it helps to contract your hip muscles to rotate the knee outwards.
So that's one example of an exercise. It can be regressed and made easier if someone's getting too much pain, so we can do smaller range of movement with it. We can make it harder by putting someone on an unstable surface, and we can progress it further by going into lunging and various other things. So the physios we work with GLAD are trained in how to progress and regress that exercise depending on the person, but alongside a number of other exercises as well, so it can be tailored and individualized to the person. So the other thing that's important about GLAD whenever you see it is it's a minimal intervention. So it needs to be individualized, and we can also add things. So you may do additional exercises, you may have other treatments like taping or manual therapy or other things, but the key is getting that minimum dose of exercise. So before we start exercising, and I'm sure there's plenty in our online webinar tonight who are sitting there going, but exercise really hurts my knee, or it really hurts my hip or shoulder, or whatever it is that you're managing. And one of the key things we need to have a good understanding of is that lack of strong relationship between pain and damage. So pain is a warning system. So we typically feel pain not because we're damaging a tissue, but because our brain's getting messages about movement and pressure and other sensations, and it's perceiving them that it may actually be dangerous to the tissue structure. And so what happens when someone has had pain for a long period of time, that alarm system that goes off becomes really sensitized. And so you don't need a lot of movement, and you can do this yourself if you've got a sore knee or a sore hip. Just a small movement will cause pain. Small palpation or push on the joint can cause pain. But it's very unlikely, and it's almost impossible, that that small movement or little push is going to be causing any damage. So that's your pain system going into overdrive. So it's almost impossible for someone who's had persistent, long-standing pain because of osteoarthritis to do exercise without pain. The key is to make sure that it doesn't progressively increase through a session, and that it settles back down to your day-to-day pain within that sort of 24 hours. So if the following day your pain is back to what it has been, then you can be really confident you haven't done too much and you can gradually progress things. If, however, your pain increased for 2 or 3 days, that's not the end of the world, but you might go, okay, maybe the next session I might do a little bit less. And this is something where an exercise professional like a physio can really help you and guide you through this process as you go along and modify things for you, or you can have a go at modifying it yourself. The other thing that we need to make sure that we have a good understanding of, and thinking about busting myths around that, not just the lack of relationship between pain and damage, is we don't want to think about osteoarthritis as a wear and tear disease. We are not cars, we are not vehicles. Our tissues are living. And what that means is that some exercise is actually beneficial for our joints and keeps them healthy. Too much exercise can cause them to deteriorate and can cause structural change, but so too does not enough exercise. So we actually need to consider our joints as living, and they need load to stay strong. So we often see scans being overemphasized. And I say that because if you look at the population over the age of 40 and we do an MRI on, say, 100 people who don't have any knee pain at all, in about 40 of those people, so more than 40%, we would actually see changes that indicate structural osteoarthritis, yet they have no pain. So there's not a good relationship there. And so we can sometimes get stuck on trying to treat what we see on the scan, which makes us think about surgery, when actually the pain that they're experiencing is far more influenced by other factors, which might be related to that person in the joint that we can't see on an image, or person-specific factors. So if I outline some of those, and we could go into much more detail, but mindful of time tonight. But we have osteoarthritis, we have the changes in the structure, which we might see. Most of those changes are not related to pain, but it might also be influenced by obesity. A lot of people think about being overweight as being extra load on the joint, But an interesting fun fact about osteoarthritis is one of the biggest risk factors for hand osteoarthritis is being overweight. So it's not so much the mechanical load of being overweight, but it's more so the metabolic effect it has. So we know that being overweight is bad for our heart, but being overweight can also be bad for our joints because it causes systemic inflammation. One of the best ways to counteract that is obviously to think about how can we lose weight, but even if you can't lose weight, that's okay. If you can do other things like be more active, eat better food, things that would reduce systemic inflammation, that can be incredibly helpful too. So sleep and physical inactivity can be a problem. Muscle weakness, which we can assess for, can be a problem and end up leading to more loading of the joint. We may get too much load, so it might be related to injuries and other things. And there's a whole range of psychological factors. So people who are really worried about exercise and loading their joints will typically have more pain and more disability. People who have depression or anxiety will typically have more pain. Pain's an emotional response. So if we're not doing well from a mental health and psychological perspective, then our pain is typically much worse if we feel stressed, if we feel isolated. So sometimes people's symptoms can be influenced by a range of different factors, and it may have nothing to do with the joint structure. So when we're thinking about what are the levers we can pull to reduce someone's pain, this is really just a brief whistle-stop tour of some of the things that we might consider. And I'm sure you can reflect on some of them yourself if you've got hip or knee pain or any other joint pain for that matter. And so I've talked about exercise not being harmful for osteoarthritis. What I want to now do is shift your brains to think about why exercise is important for osteoarthritis. So there's the obvious things like building strength, and that helps us to get better support for our joints, better control. But actually, we also need to do weight-bearing exercise and load our cartilage to keep it healthy. So when we load our cartilage, the best way for you to think about it is it's like a sponge. So one of the analogies to think about, it's kind of like a piece of coral that has water content in it. Even if it's thin and you've been told you've got bone on bone, you'll still usually have some cartilage there. When we stop loading that exercise, there's no stimulation for nutrients to come into that cartilage. And those nutrients are vital for keeping it healthy because they help it to hold water content in when we're doing exercise. So it's got more cushioning, and they help it to recover from exercise. So not doing exercise for a period of time means there's less concentration of those nutrients. Now, if we progressively increase our exercise, we get more and more nutrients to the joint, and it gets better and better at absorbing that water and retaining the water, and therefore gets better and better at handling loads that it takes through. So it actually provides nutrients to the joint and provides nutrition to the joint to keep it healthy when we do exercise. The key is not doing too much too quickly. So by doing exercise, we can improve our joint movement, stability of the joint, we can move better, we can move more confidently, and we can actually keep our cartilage healthy. And that's a really important message that you need to remember. So I want to go back to Helen because this has got some really important messages, and she'll talk through her story of what she did. And one of the programs we got her to do was GLAD. So we'll talk about that a little bit here as well.
After 6 months of that rehab and developing osteoarthritis, how were you feeling about exercise?
I was given the wrong exercises. It wasn't adapted to my condition. The muscle atrophy, I just had no muscles in my legs whatsoever. And the exercises I was given gave me more pain.
Now, you were eventually referred to a second physiotherapist who said he could treat you. What changed then?
What changed? Wow. First of all, he had a look at my condition. He fully tested my knee. I was there for the first time for about an hour, and he gave me really basic, simple steps. And my knee was so unstable and so much pain. And he gave me 4 really basic exercises, mapped out a plan. And I can remember walking out of that appointment saying, I'm going to get better.
Now, was this Christian sitting beside you?
St. Christian, yeah.
Yeah, St. Christian. Okay, so tell us about this. I mean, what shape was she in, and what did you think of what she'd been told prior to
So I think Helen had been told she should have an arthroscopy and possibly going down the lines of knee replacement. We discussed before about the detriments of not exercising for lots of things. And one of the other things we know is that exercise is incredibly important for managing osteoarthritis, which is what Helen was now dealing with. We've had evidence for that since 2002, that should be something that should be implemented in our healthcare system. Yet 3% of patients are referred exercise therapy in Australia from a GP setting on average. So it's from a big database set. So when I look at Helen, it wasn't so much that
there wasn't anything to be done. We needed to give her the right exercise program. I looked at the atrophy of her legs, and to put her on a leg press machine, a leg extension machine, which they've tried, was just far too advanced for where she was at, for the level she was doing. So we started with really simple things. And the other thing that we spend a lot of time with as physiotherapists is educating patients about pain. And it's okay to have pain during exercise. It's about what we think about that pain as, because pain doesn't always equal tissue damage.
And this is a very important point, isn't it? Because it's kind of counterintuitive. People have been told for years, stop when you feel pain. But in the case of osteoarthritis, that's not true.
Definitely not the case. I mean, there's some common misperceptions. Things like running, for example, people would believe are bad for knees and could cause knee osteoarthritis. Actually, we see recreational runners have lower rates of osteoarthritis compared to someone who's sedentary. We go to the other end of the spectrum and they're competitive runners, they'll have higher rates. So we know that some level of load and exercise is incredibly important, not just for osteoarthritis, but for tendon health, for muscle health, for a lot of other things as well.
But you've got to do the right things, because if you do the wrong things, you can make it worse, which Helen had been through.
Exactly.
So you need the right advice.
Yeah. So what we did is we pitched the exercise to Helen with something which was achievable for her, education about pain, and then we progressively increased that exercise over a number of months, and referred her to a structured program as well, where she had supervision with a physiotherapist. And that was a group exercise class, which Helen did over a 6 or 8 week period, so she could really get that kick started. And I think beyond that, mostly you went to the gym from there.
And what happened?
I've still got a way to go, but I come back to normal. Yeah. You know, and with me, you get up in the morning, you do some exercise, it sort of kickstarts you. And yeah, my life sort of come back to normal. I had a lot more energy. I could walk down the street. I could get simple things. I could get out the car without doing the Lady Diana, 2 legs out. I could cook and turn without thinking. I could get off the couch.
So Helen's outcome ended up quite well, and the program, the structured program I mentioned, was glad that we sent her to. But the key thing for her wasn't just the exercise part, it was also that education and busting the myths around pain and making sure that we didn't pitch the exercise too high initially. Now, she ended up doing leg press and leg extensions, ended up getting back to running. I still see Helen occasionally now. So that interview from SBS Insight, I think, was 2018. So 6 years on, she's still going along well and still hasn't had that joint replacement she was told she would need, and her knee's still functioning quite well. So if I go to the broader picture of GLAD and we look at the outcomes that we've achieved, and we've looked at outcomes as well with telehealth and various other delivery methods, and we all end up with similar outcomes. But in the real world with GLAD, we typically see 3 in 4 people who do the program will report clinically meaningful improvement in their pain and quality of life at 12 months. And importantly, in those who desire surgery, which is about 20%, 3 in 4 will not have that surgery and no longer desire the surgery at 12-month follow-up. So that's for the knee cohort. The outcomes for the hip are similar, not quite as high, but still pretty reasonable. So we see some really good outcomes. That doesn't mean that everyone benefits, but the vast majority are likely to feel like they've had improvements after the program. The GLAD program has really grown. It surprised me at how much it's grown. There's a few barriers, which I'll talk about in a minute, but we've now trained, actually, this is from the annual report in 2022. We're actually now over 3,000 physios we've trained. We have more than 20,000 people in our registry, and it's offered across every single state and territory in Australia. And the average pain changes that we see are around sort of 25 to 30% for the hip and knee. We see a reduction in medication consumption, significant improvements in quality of life, and also increase in physical activity participation following the program. So it's having a real meaningful impact across the country, which is really nice to see. There's been a lot of people involved. I won't go for each of the names, but just to highlight, this is a big project with a lot of people and really an army of physios and exercise physiologists driving the program. So why don't more people do GLAD or do other types of exercise? Because unfortunately, when we look at our research about who does what prior to, say, seeing the surgeon, probably more than half have not done appropriate care. And so I like to look at this as a socio-ecological problem. So if we look at the figure we've got here, we have the person's behavior. So that's you with knee osteoarthritis or hip osteoarthritis, and the treatment choices you make, or the treatment choices you go down the path of. And we really need to think about intrapersonal factors. So beliefs, knowledge, self-efficacy, that is the belief you can manage things, motivation, and skills. So some of them are really driven by thoughts, and those thoughts are often influenced by health professionals. So being told I've got bone on bone and I need a new knee. So when you're thinking like that, doing exercise doesn't make a lot of sense. too worried about exercise doing more damage, but hopefully we've busted that myth a little bit. Being shown how to do exercise and how to progress it and what to do can be really important. Hopefully I'll have some self-directed resources that you can use, but also seeking some care from a health professional can be useful. On the health professional front, we've done lots of research on this, looking at physios, looking at GPs, rheumatologists, a whole range of different people. And essentially, these messages about bone on bone and that wear and tear disease are unfortunately reinforced by our medicos. And so that can be a big problem. We also see that physio is quite variable in the treatment that's provided. So some care you receive is really focused on passive interventions like massage and taping and needling and these things, which might be helpful in the short term, but aren't necessarily helpful in the long term. We've had some really great stories get out there in the media. So we've had GLAD and other exercise interventions talked about on Channel 7, for example. But then we get the naysayers who really just talk down the potential for exercise to help. Now, remember, we're not saying that exercise is the only thing to do. It's just the first thing we should do. So that's a really important message to get across. And then one of the biggest barriers perhaps to getting support is the socioeconomic factors. And that is that really there's not a lot of great funding for exercise services. So to go and see the physio or the exercise physiologist, you're often out of pocket, whether you've got Medicare funding, private health funding. The programs are not really very well funded. We are seeing some improvements in that in recent times from some of the private health funders. So hats off to HCF and HBF who are funding GLAD now, and many others are starting to work on some initiatives to fund exercise services, which is great to see. I want to show you one other little case study just briefly. So I show you this case study because it's an interesting case where actually for Lawrence doing the joint replacement surgery, so a full replacement of his knee, this is an x-ray of them, would have been less expensive than going and doing physio to try and avoid that surgery. And he didn't really think that exercise was going to help until he almost had a cardiac arrest. So I'll just let the story play a little bit and I'll talk a little bit more about it in a second. So I'll just play this for a couple of minutes. It's quite an interesting story.
Two years ago, a physio that I know very well said, you know, you don't have to have that knee operation. You can do it with exercise. I scoffed at him and I thought, I don't believe you. I've certainly come around to eating my own words over that. And then we said, give the GLAD program a go. And I went along and I did that and it really seriously changed my life. I was able to now walk without any difficulty. For the previous year, I was using a walking stick. I couldn't get around without a walking stick. To say it was a miserable life was not understating it. I was in a lot of pain. The education program initially for me was to do with diet, medication, all of that sort of stuff, psychological, et cetera, et cetera. In the GLAD program, the training and adhering to the perfection of the exercises so that you do the exercise the right ways. And so the education is fundamental. You have to listen and you have to put it into practice. After about 4 weeks, I thought, actually, this is getting better. And I thought, oh, this is not hurting. I'm slow, but it's not hurting. It's improving. That, for me, was where I felt I'd turned a corner and I thought, this is a really positive thing. It's real.
So I won't play the rest of the video, but I will highlight, and it's not in this video here, but I can certainly send out along with some of the slides so you guys can see it if the team can send it out and this paper, is that Laurie ended up doing GLAD and doing exercise, not because he chose to, but because he couldn't have the joint replacement surgery because of his cardiac health. He had to have sudden cardiac surgery, which led him to doing exercise, addressing his lifestyle, and then he went into GLAD and he did a program to address his strength and his function. And then suddenly decided he didn't need the joint replacement surgery. So interestingly, it was his heart that almost killed him, but also saved him from doing the joint replacement. Now, he's now about 6 years on and still hasn't gone down the pathway of joint replacement, is still functioning really well. And those who like to obsess about x-rays, this was Laurie's x-ray just prior to that time. So he's done a really, really good job and has had a really good outcome. So you guys can have a bit more of a read and a watch of that story down the track. So I want to finish with one other story, a case study, because I think case studies are really powerful and they help us to really understand things before I go into some resources that you guys can use. So this was a 78-year-old who self-referred themselves to GLAD, did it at a different clinic, so not where I work. I ended up seeing him later. This is an x-ray of his knees. He was told that he needed a knee replacement for his left knee. He wasn't really keen on that idea, so he decided to try some exercise. He started GLAD and he said to the GLAD clinician he was going to see, this will be a waste of time unless you can get me back to running half a marathon. So most of you will go, 78 years old, he wants to run half marathon, but his whole life he'd been a runner. So his exercises, he was doing home gym, some weights 3 times a week. He was cycling instead of running, but he was really disabled by his knee. So his outcomes with GLAD were that he actually felt really confident. He changed his beliefs about exercise and it potentially being damaging. His average pain went from 70 out of 100 down to 26 out of 100. His worst pain didn't really change much because he kept trying to do things like running. His chair stands, how many times he can stand up from a chair in 30 seconds, increased slightly. His walking speed didn't increase, but it was already fast. So he had some improvements. He was more confident, had less average pain, but his worst pain was still high. And he still wasn't back to running. So it helped address many of his impairments. So we've reduced the pain-related fear and his concerns about his imaging. He was not avoiding activity so much. We'd improved his strength, started to improve some of his power and improved his quality of life. So he was on the right track. But GLAD didn't get him back to running. So the half marathon quote that he said, it was perhaps a waste of time. But when he tried to run, he flared up again. So he come along to see me. So we employed some other strategies to try and build his capacity running. And I show you this not because I want everyone to go back to running, but just because even a program like GLAD, it's often just a starting point in the journey. It's a 6 or 8 week exercise program. And often if we want to improve and reach our goals, we need many, many months. So over probably the next 8 months or so, we added speed to his exercises to improve muscle power, more resistance. We worked on other muscles. We did things like added weights to his exercises. We did some trunk strength. He was doing things like planks. We set him up with a walk to run program. We taught him some strategies to improve his running mechanics a little bit. And this is something you can try if you've got hip or knee pain. You might try taking shorter, faster steps because that can reduce load. So that's something we use for his running. And we continued to educate him about flare-ups and that they might happen, and they certainly did. You might get some fluctuations, but they will settle. So over the space of 8 months, he built his strength, he built his capacity, he built his walking capability instead of just the bike, and he slowly returned himself to running. And I promised him that I'd do park run with him if he got back to being able to run 5Ks. So I kept to my promise, and this was us 8 months on, and we went and we did park run. You'll see his times here. So in just before Christmas, 35 minutes-ish. Early in the new year, he was down to 32. He got his times back under 30 minutes and he got up to running 15 kilometers. He didn't quite make it to the half marathon distance, but he got back to 15 kilometers. And the only thing he's complained to me about recent times is not knee pain, because his knee doesn't hurt when he runs anymore, but his times are getting slower again. He's now struggling to get under about 38 minutes. So that was Neil's journey. On our clinic website, I have a blog written about it, so you can do some more reading on that. So I want to finish and give you something you can really take away and continue to learn, and share a study we did with Dr. Anthony Goff, who was a PhD candidate of us with Trobe, and we co-designed the My Knee education and self-management toolkit for people with knee osteoarthritis. I won't go through the methods in huge detail, but in simple terms, it was informed by end users, so people with knee osteoarthritis who are going to use the platform. So we looked at what their education needs were, and we did a study called concept mapping. So we got them to list all the things that they thought was important to be on the website, lots of things about exercise and surgery, lots of things about understanding their symptoms, lots of things about other treatments and adjunct options. So we made sure we covered all the things that they wanted to cover. We used evidence, we used a whole range of things to inform the site, and then we did workshops with people, and we actually got them to help design the program. One of the things I will highlight from our methods is the priorities of people with a lived experience of osteoarthritis do not match up with what guidelines recommend people are educated on. And I say that because we often rely on guidelines and all these resources to tell us what we need to do in clinic, but it doesn't always meet the needs of consumers. And I think talking to a consumer organization, I think this is a really important message for all of us. So the website has many different resources. So there's videos from experts, there's videos about education and self-management, about diet, about exercise, about injections, about surgery. You can create your own guide, which is an interactive setup. So I'll encourage you guys to have a scroll through that. Even if you don't have knee osteoarthritis and you have, say, hip osteoarthritis, it's still well worth scrolling through and you'll learn a lot. Those that want to jump onto it very soon, that's the website. It's myknee.trekeducation.org. You can actually just scan the QR if you've got your phone there, just pop it there and scan it, and you'll be able to jump on there. If you want to learn more about how we actually developed the platform, you can scan the QR code there. We've been testing it using it as a self-directed resource compared to supervised exercise. We see some very good outcomes with just using this resource by itself. Maybe not quite as effective as supervised exercise, but for many people, it can be really, really helpful. So hopefully you'll find it useful to use and to go through beyond tonight if you're struggling or friends or family are struggling with managing their osteoarthritis. So I'll finish and give you some take-homes. I guess I have to acknowledge there's many people I don't have time to list them all to say thanks to, funders and research collaborators, GLAD and TREK. But the key take-homes are exercise and physical activity are the key to managing osteoarthritis well. We do have other treatments and they may help, but they do not replace exercise and physical activity. So that needs to be the cornerstone of what we do. Exercise is typically good for your joints, not harmful. And you need to find your own pathway to engage in exercise. So I've talked about GLAD, there's many other exercise options. I've talked about the TREK platform, which you can use to help. Not everyone's journey will be the same. And if your first try of exercise is not effective, don't give up on exercise. There's many different options and the benefits from a health perspective are really huge as well. So it's not just about managing osteoarthritis. But I'll say thank you and I'll open up to questions.
Great, that's wonderful. Thank you, Christian. That was really, really informative. And we've got some questions going, which I will address in a second. But one of the take-homes from your presentation there, Christian, is, and I'm going to keep using your analogy, this is a marathon, not a sprint. And so when a doctor, when a healthcare professional says you've got OA, you need to start exercising, we need to get ourselves in the mental space that perhaps doesn't mean running out, joining the nearest gym, becoming a CrossFit champion, running, sprints around a track. This is going to be something that we're going to work with over time until we find the right combination of exercises that is right for us and going to improve our health and our knee OA. Is that a good takeaway from it, Christian?
Absolutely. That's a really good, and I probably didn't highlight this well enough, but I guess we've been talking about therapeutic exercise. So you might be doing strength training or building muscle capacity or doing exercise to build your confidence in your joint, whatever it is. But ultimately you want to do that to build your capacity to do what you enjoy doing. So if you enjoy dancing, if you enjoy paddleball or tennis or walking or running, if you can use therapeutic exercise as that part of that journey, that marathon you're talking about, to get your capacity to do that, then you can hopefully engage in something you really enjoy that helps you stay active. And then you get the benefits to your joints that keeps them healthy, but you also get benefits from what physical activity brings us. Remember I said 35 different chronic diseases. So heart disease, diabetes, your mental health and well-being, all these things. So if you're really struggling to engage in exercise, try some things you can do online, but also I think wherever possible, try and seek some support from an exercise professional to build your capacity to get back to doing the things you enjoy. So it can be an enjoyable marathon rather than a not so enjoyable marathon.
And just drawing on that a little bit further, Christian, is it that we also need to perhaps rethink the way we view movement and exercise? And in the first instance, as you and I were discussing briefly before the session, it might be that engaging in something like, as you said, warm water or chair-based exercise as your starting point, so that you can mentally start getting yourself thinking, oh, this is moving. Okay, I'm getting a little bit of pain, but it's not a bad thing. And using that as a platform from which to then move into the weight-bearing, walking, weightlifting, those sorts of exercise regimes?
Yeah, absolutely. So chair-based or water-based can be a really good starting point as a stepping stone to getting into more weight-bearing exercise, which we hopefully can progress people to. The other benefits of doing chair-based exercise, an example, is often you can do some really good knee strength in sitting without putting too much load through your joints. So that's something you can work on. From a water-based perspective, you're probably not going to build strength with that, but it's a much easier form to get your heart rate up sometimes. And so you might use it to do that. So there might be other health benefits of doing those forms of exercise. So even if you've got hip or knee osteoarthritis, you might start with water-based to get yourself going, but you might continue with water-based in the long term alongside land-based because of the potential aerobic benefits you get from that form of exercise too.
Fantastic. Now, I better jump into some of the questions that our viewers have been putting up. Now, one of the questions Annette asked is that she's got OA in every joint, including her neck and spine, as well as fibromyalgia and DDD. So for her, it's really hard when you're told to exercise, particularly with fibro, and you can't exercise too much. What can she do?
Yeah, so I think probably just touching on what we just talked about then, for someone who's really struggling to do any exercise, I think trying to do something like warm water pool-based exercise as a starting point might be really helpful. You'll get benefits from exercise for strengthening and loading joints and things like that, but you'll also get benefits from doing aerobic exercise and just getting your heart rate up a little bit, because that will reduce systemic inflammation, get natural release of endorphins. So hopefully getting in the water can be useful. You can look at chair-based exercise, and maybe you can do some gentle leg exercise and arm exercise to try and get your heart rate up just a little bit, and that might be helpful. I think that's where definitely working with a multidisciplinary team is really important. So if you've got fibro and other things, working with a good rheumatologist and or your GP is their medications or dietary approaches that can help you manage some of those things. And that can make it a bit easier to engage in exercise. And it might be you have windows where you can do exercise well and you can make good progress, and other windows where a rheumatological condition or your fibro or something like that might actually flare up, in which case you need to take a little bit easier. And certainly working with an exercise professional can help with that, but also making sure you're working with good GPs and rheumatologists to support and guide that. So I think where to start is what you can do. So just keep experimenting and try and work out what you can achieve. And if you can't achieve what we say is the gold standard of doing land-based, that's okay. Doing something as a starting point is very helpful.
Now, you raised an interesting point there about multidisciplinary teams, and Lorna has made a comment that she's in a rural town in WA, and all of the programs are Perth-based.
Yeah.
And she's run out of physiotherapy and exercise physiology on her private health insurance. She's joined the cheapest gym in town to try to keep doing some exercise, but that kind of support is just not available for her in this rural location. So is that where these sorts of platforms, online platforms that you've started to develop and are pushing out, might provide another layer of support for people in rural and remote communities?
Yeah, hopefully. So the Trek education platform, which I mentioned, so that's the link to Trek, which has many things, not just osteoarthritis, but within that you'll find the My Knee site. So that's hopefully a useful resource. There's exercise videos and exercise guides you can use and a whole range of other information. So hopefully that's a useful self-directed resource. I don't think that can always replace having an exercise professional. So if you live in rural and remote areas, one of the, I guess, positives to come from the pandemic is people become a little more open to doing telehealth. And there's certainly some good telehealth services. So Glad, which I mentioned before, that can be delivered via telehealth, and there are different clinicians. So you're not locked to seeing people in Perth if you use telehealth. You could see anyone in Australia who's happy to use telehealth as a clinician. That doesn't get past the funding issue, and that is that someone still has to pay for it. And unfortunately, there's not a lot of great government funding for in-person care, let alone telehealth care for these things. So I don't have a solution to that other than try and use the free resources. And that's why I've been working hard to make them, and hopefully talk to your private health insurer and pester them to maybe fund a program like Glad via telehealth. Some of them are starting to fund it. So HBF and HCF have come on board. I don't think they've jumped on board doing it via telehealth, but it's something they're looking at. And the others are all looking at this as well. So definitely see if you can can convince them to do it, not just for you, but for others.
And I think, you know, Christian, there's an interesting point there, is that we are working with the APA, Australian Physiotherapy Association, on some advocacy work around lobbying the federal government to really consider how physiotherapy can be better funded within the public health system as a real support for musculoskeletal health and well-being. So that's another piece that we're heavily involved with as well. Now, we've got lots of questions going on, but I have this one that I think is one of the best questions I've seen from Colleen. She asks about osteoarthritis in the feet and ankle pain and flare-ups there. And her question relates to, is line dancing still okay for feet osteoarthritis?
Yeah, what a great question, Colleen. So I guess I'd encourage you to do a couple of things. Try a little bit of line dancing and see how your pain responds. So if it gets really sore for a couple of days after line dancing, that doesn't mean line dancing's bad. It just means you might not have the muscle capacity. So you might need to do some strength work for your foot and ankle to get it stronger to be able to cope with that. And so you might seek some guidance around that. I don't have any great resources online for foot and ankle OA, I apologize, but certainly see an exercise professional can help. And then the other thing is, when you think about dance classes, or lots of classes for that matter, they often will go for an hour or an hour and a half. And so as you go back to an activity like that, don't get too carried away. So if you're going back into it and you've had a sore foot and ankle or a sore knee or sore whatever it is, be happy to go back and do it for 10 minutes and then do the social part. And then change that 10 minutes the next week into 15 minutes and then 20 and then 25, and just gradually ease yourself back, because the body's clever. It responds to the stresses placed on it. So as long as you don't put those stresses onto it too quickly, so too much too soon, it'll often do okay. So that's a long answer to your question. The short answer is, don't give up on it. Just slow and steady, try and get back. And I think look for some support to get stronger to support you to do line dancing if that's something you really enjoy. And there's a good chance you'll be able to do it.
Now, this is a really interesting question from Maxine. How do you actually tell the difference between a flare-up and that chronic pain that you're living with?
Yeah, so I think if you've got chronic pain you're living with, there'll be certain tasks that are just sore. So I'll use an example. If you've got a flight of stairs at home, you walk down the stairs in the morning and you've got a 3 or 4 out of 10 pain as you walk down the stairs, or you stand up from sitting and it's a 3 to 4 out of 10 pain. So that's a consistent thing you'll often feel. And so if you get a flare up after doing some extra walking or riding or line dancing or doing an exercise program that your physio gave you, then you might find the next day that actually that pain's 5 or 6 out of 10 or 7 out of 10. And that might last for a couple of days. So that's a sign that you're getting a flare up as opposed to it just being your day-to-day pain. So you usually have those consistent symptoms. And what we typically find with people who can engage in, say, an exercise program like GLAD or a self-directed one and slowly progress it, is that 3 or 4 out of 10 pain I described before, over a 6-week period, it might become a 1 or 2 out of 10 pain. And so that way we know we're on the right track. But if you're finding that the day after doing your exercise that it's more of a 5 or 6 or it's increasing, then that tells us it's maybe a flare-up and you need to slow down a little bit.
Now, there's a couple of questions that seem to have a similar theme that I'm reading here, Christian, and this is around how does all of this affect tendons, ligaments, and soft tissue around the knee as well?
Yep, that's a great question. So when you have osteoarthritis, you typically got this chronic inflammation around the whole joint. And so we don't really know which structure is the painful symptomatic structure often. So it might be related to the joint and underneath the articular cartilage, for example, but it might also be capsule around the joint that's been irritated by an inflammation. It could also be tendons and muscle around the joint. You may have pain that spreads quite wide. So you see this particularly in the knee, where it's not isolated to one point. It sort of hurts on the inside, the next day it hurts on the outside, then it hurts on top, and it might be inflammation around the muscle. It might be muscle tightness and fatigue. So it can certainly affect pain in all different areas. From an exercise perspective, going back to, I talked about cartilage and the benefits of doing exercise for keeping your cartilage healthy. actually, out of all the structures that we've just mentioned there, cartilage has the least ability to adapt. So it's the slowest, whereas muscle and tendon and those other things, if we exercise and progressively increase the loads, they actually adapt much better and much faster. So usually you can find your symptoms get less widespread as you do more exercise as well.
Excellent. Now, a final question before we wrap up, and this is from Teresa. She wanted to know, is the GLAD program available in Sydney? But I suppose a broader question is, where is the GLAD program available?
Sure. So you'll see the dots on here, and I think this is a slightly outdated map, but that was a capture I took a while back. So it's in every state and territory. So that's number one. So it's definitely in Sydney. There's a lot more offerings in Victoria, which is where we started it compared to other states, but there are over 700 sites in public and private settings across the country now. So it's quite widespread. The best way to find out where your closest one is, if you're interested, if you go to the gladaustralia.com.au website, there's actually a locations tab on there, and you can click on the locations tab and you can type in where you live, so your postcode or your suburb, and it will tell you where your closest GLAD clinics are. So it's nice and easy to find from that perspective.
Brilliant. And we'll certainly make sure that we've got all of those links on our website as well, Christian. So if people head to our website, they'll be able to get to where they need to find the information. So on that note, I want to say a huge thank you. What a fantastic presentation tonight. We've had over 110 people online listening to you, Christian, and I think the number of questions highlights how impressive and amazing the information you delivered this evening has been. I also wanted to thank our sponsors for this evening's webinar, the Peninsula Hot Springs. So thank you so much for your ongoing support of Musculoskeletal Health Australia. As I said, this recording will be available over the next couple of days, and we will certainly send out an alert to let you know when it is available. We'll have all the links that Christian had in his presentation tonight on our website, so you can get straight to the information and start getting active and getting moving. And thank you so much for this amazing work, Christian. You're fighting the good fight for musculoskeletal health in Australia. So thank you so very much.
Thanks, Helen, and everyone. It's been great to be on.